Today we will talk about procalcitonin, the biomarker that is reshaping pediatric sepsis diagnosis. Let us start with a clinical case. A child arrives at the emergency department with fever, lethargy, tachycardia, and elevated inflammatory markers. Is this early bacterial sepsis requiring immediate antibiotics, or a severe viral illness that could resolve without unnecessary antimicrobial exposure? In pediatric medicine, that distinction can mean the difference between life-saving intervention and over-treatment. And increasingly, one biomarker is changing how clinicians approach that decision: procalcitonin, or PCT. Procalcitonin is the precursor peptide of calcitonin, normally produced in the thyroid C cells at extremely low concentrations. But during systemic bacterial infection, something remarkable happens. Under stimulation by bacterial endotoxins and inflammatory cytokines such as IL-1 beta, TNF-alpha, and IL-6, procalcitonin production becomes widespread throughout the body, particularly in parenchymal tissues. Levels can rise within just 2 to 4 hours, often peaking by 12 to 24 hours. What makes procalcitonin particularly valuable is its relative specificity for bacterial infection. Unlike CRP, ESR, or white blood cell counts, which rise in many inflammatory states, procalcitonin tends to remain comparatively low in most viral infections. One proposed mechanism involves interferon gamma, produced during viral immune responses, which suppresses PCT expression. This gives clinicians a potentially powerful tool for distinguishing bacterial sepsis from viral systemic inflammation. In pediatric sepsis protocols, this has major implications. Studies increasingly show that elevated PCT correlates with bacteremia, severe bacterial pneumonia, meningitis, and systemic sepsis severity. Serial measurements may also help monitor treatment response and antimicrobial stewardship decisions, potentially reducing unnecessary antibiotic exposure, a critical issue in the era of antimicrobial resistance. However, procalcitonin is not perfect. False elevations may occur in major trauma, surgery, burns, severe malaria, prolonged shock, and some neonatal physiological states. And importantly, no biomarker should ever replace clinical assessment, blood cultures, molecular diagnostics, or microbiological correlation. The future of pediatric sepsis management is likely moving toward integrated precision diagnostics, combining biomarkers like procalcitonin with rapid PCR panels, host response signatures, and AI-supported clinical algorithms to identify sepsis earlier and more accurately than ever before. Because in sepsis, timing is everything. And two tests matter the most: procalcitonin and lactate. The ability to distinguish bacterial infection from generalized inflammation within hours may dramatically alter outcomes, antibiotic stewardship, and survival itself. If you enjoy evidence-based microbiology, immunology, and clinical diagnostics explained in depth, subscribe to Science for Fun Academy for more medically grounded educational content.